Sorry for that. So briefly an outline, I'm just going to introduce our discussion. And so that we're on the same page, I will define what I mean by clinical education and what is the purpose of clinical education. And clinical education practice in Zambia, where are we? What are our challenges? Now, I'm aware we have colleagues from who are not from Zambia, from out, they're connecting from other countries. And the status that I'm going to give and the challenges, you may just see that we are, if you're advanced, we'll be learning from you. If you're at the same level, we are learning together, and we'll continue sharing the way we do things in terms of educating our radiography students. And then we're going to look at the strategies to improve the clinical education in radiography, and also have a few recommendations that I will share with you in terms of how we can improve the education of radiographers in Zambia and, let me say, in Southern Africa. Sorry, it's getting stuck. I'm not sure why. When I go to the next slide, I can't move. Sorry. Where is my network? Sorry, let me just disable you again. What's happening? Eh? Video. Okay, I hope it will behave now. So clinical education basically is, we're talking about the teaching and learning that occur in the clinical context. Okay, we are radiography training or learning. We are all aware that we do it in two parts. There's a time that our students are in class, academically, they learn theory. And then there's time that we want them to practice what they learn so that they can attain a competence for them to work in the real world as radiographers. So today we'll be talking about that part of learning where our students learn from a clinical setup, where the students are exposed to patients and other clinical environment for them to learn how to do radiograph practice. So it's of paramount importance that we prepare our students for that practice. And because of that, our curriculum in Zambia for radiographers at all the 4 institutions that provide radiography teaching, these are University of Zambia, Osaka Medical Apex University, Evelyn Horn College, and actually there are 5. Cancer Disease Hospital, where we are training our radiotherapy students, as well as Levi Mwanawasa Medical University. The curricula is set in a way that 50% students are in class learning theory, and 50% they are supposed to be in clinical area they are attached to clinical environment where they learn how to actually do the imaging. Okay, now 50% clinical dependent on the university. Some universities like Levi Mwanawasa universities, they have a competence-based curriculum, and therefore their clinical attachment or clinical learning of students takes about 70% of the whole time the student will be learning radiography. So 70% of their time, the students must be doing clinical learning. So you can see how the universities have attached the importance of clinical learning, because we are aware that the more our students are exposed on the doing part of the learning, the more competent they become. Okay, so clinical teaching should be at the heart of our radiography education. And therefore, if we lack the planning on how we plan the clinical education, and we lack the skill to supervise our students, we lack the a skill to give a feedback as these students learn in the clinical area, then we are compromising on the competence that these radiographers are going to attain at the end of the training program. Okay. And so by definition, some of the points I've already alluded that this is a practice of assisting a student to acquire the required knowledge, the required attitude, and the psychomotor skill, okay, that they need to practice in the real world as a requirement by our licensing bodies or our bodies like Radiological Society of Zambia. So in a nutshell, Wanga and Sichone defined clinical education, the practice of assisting a student to acquire the knowledge, the attitude, and psychomotor skills in a clinical practice environment to meet the standards defined by a university degree structure or a professional body. Okay, so clinical environment, again, one may ask, what is a clinical environment? We are talking about an area where our students are going to learn in a practical way. It can be a radiology department, which we all know, a hospital ward, where our students go to do ward radiography, or a surgical theater where our students go and do theater radiography, orthopedic radiography. So these are the environments that we're talking about, where our students are attached to learn a practical way of doing things. Now, the problem we are having now in Zambia is that there is a gap between the theory and the practice learning. The theory is where the students are in class, they are learning the theory, and then they are supposed to cross over to apply the theoretical knowledge that they got as they were learning in class, okay, to be able to do what they are supposed to do in radiography, okay? So we are seeing a gap, and this gap is what we want to concentrate on today, okay? This gap is where us as radiographers who are already in the system are supposed to be, okay, to ensure that this bridge is complete. If we lack a competence to teach our radiographers or to transit the radiography students from theory to practice, definitely our students will be drowning down here in terms of competence, okay? So we are talking about us clinical educators, in inverted commas, to be able to bridge this gap by the skill that we have to teach our students, okay, from theory to practice. Okay, the theory part of it, I think currently we have enough expertise. We have a lot of radiography personnel who have been trained to train or to teach in a classroom, okay? But we have no or very limited number of radiographers who've been trained to teach in practical setup, okay? And we assume that teaching in clinical practice is when you have expertise to, you are an expert in radiography, for example, you have the knowledge. We always think the teaching will be easier, but that's not the case. Teaching comes with its own skill. Just like the way we train ourselves to teach in a classroom, we are supposed to train ourselves or to train radiographers to teach in a clinical setup, okay? So what is the purpose of clinical education? Okay, as I already said, it is to bridge the gap between theory and practice. And clinical education provides our students with the real world opportunities to develop the knowledge, attitudes, and skills necessary to function competently in the practice, okay? And therefore, we need to ensure that enough time is allocated to our students to learn how to do than theory alone, okay? And clinical education provides a competence experience for that radiograph student to practice as a professional person when they graduate. Remember, in the clinical area, this is where they learn through our behavior as qualified radiographers. That's role playing. The way we behave as radiographers, as we are teaching these students, they pick the professional values, okay? So if we are not aware that just the way we behave as role models. We are sending a signal, we are teaching a student. Okay, if I behave badly, I'm expecting a student to come out with bad values. Okay, so a clinical education setup is an opportunity for a radiographer student to pick professional values from us. Okay, and also the process of developing and refining the skills required to become a competent radiographer cannot be completed without hours spent in a clinical setup. So what we mean here is that students must have enough time in the clinical area for them to perfect their skill to become competent radiographers. Okay. So what is the status of clinical education in Zambia? As I said earlier, undergraduate radiography training in Zambia is a mix of academic theory and also practical clinical practice. So 50% or 70%, depending on the institution at which you are, but on average, 50% theory, 50% practice. So overall, the purpose is to develop a competent radiography practitioner, okay, with appropriate knowledge, which they get from theory, okay, appropriate psychomotor skills, these are the doing skills, the performing skills, and the attitudes which are required by the profession. Okay, the Health Professions Council of Zambia, Radiological Society of Zambia, we have ethics that we want our radiographers to follow. So these ethics are learned through clinical practice and through the exhibition of behaviors by the qualified radiographers. So if a radiographer, senior radiographer, is not taught that in clinical teaching, actually, clinical teaching does not just need us to have the expertise knowledge to say, okay, radiographer, you can define radiographer, you can define how to do this, you can tell a student to position a hand, lateral or oblique. No. Clinical education is about also showing a student that for you to perform competently, your behavior must also be of a competent radiographer. If it means wearing a uniform, it means answering a patient in a way that a patient feels they are at home and they can cooperate. All these attitudes are supposed to be learned in the clinical area. Theoretically, a lecturer may mention that, okay, when you're in clinical area, you must greet a patient. But when they come to clinical area and they find that as radiographers, we do not greet patients, those are the attitudes that our students speak. So when they go to work, this kind of attitude has repeated itself. And we are the first ones to start saying, these attitudes of radiographers, but these attitudes are learned from who? Is from us. So what are we talking about? We are saying the current clinical education must be improved to ensure that our radiography students are competent enough to cater all the learning domains of attitude, of psychomotor, and knowledge. Okay, so currently, I would say in terms of clinical education, we have a base, we have something that we are doing, okay? We have training institutions that are providing preclinical practice. This is after they have taught theory, they have a clinical laboratory where our students are taken to simulate exercises where they are mimicking the real imaging world in inverted commas. Okay, they have situations where they are doing radiography on the artificial or rather not real atmosphere, but is close to real. Okay, so this is to prepare them, okay, for the real practice. And in simulation, you are allowing a student to make as many mistakes as they want as they are perfecting their skill, because you are not scared of radiation protection issues, not scared of patient rights, not scared of privacy. They are working on things that are not real, but you are providing them with an opportunity to practice as much as possible before they come to come and touch real patients. Okay, so students have an opportunity to practice without fear of compromising on patient safety, for example. and it prepares them with the confidence for real clinical practice. Okay, so that's one. Number two, we have a program of all students to go for clinical attachments. Okay, so the preclinical preparation usually begins year 1 to year 2, depending on the university again. They learn practical, the theory, they want to be shown how they can do that, what they have learned in theory. Okay, then when they get to year 2 or year 3 or year 4, depending on the program period, for those for 5 years, like Levi Mwanawasa, students will go for clinical practice from year 3. Okay, some universities will start as early as year 2. Like Cancer Disease Hospital, students are exposed to clinical education the first year they come. So we call it year 2 because the first year they're exempted. Okay, so year 2, they start their clinical attachments. Now, again, depending on your school program, others do a rotational program like Cancer Disease Hospital. 2 weeks they're in class, 2 weeks they're in clinical area where they are learning to do the actual radiography. But most of our diagnostic radiography programs, we have a time when they are sent to clinical practice attached for a continuous 3 to 4 months or the whole term, okay, in clinical area. So when these students are in the clinical environment or clinical area, by default, all qualified radiographers in Zambia, I don't know about the other countries, but in Zambia, by default, all qualified radiographers who are working in hospitals where these students are attached, they assume a role of a clinical educator. Okay, so they are clinical educators. Again, the semantics of weights, other people say clinical supervisors, clinical tutors, clinical preceptors. So as long as you are qualified, you are supposed to be teaching students in the clinical area. Okay. Of course, we have appointed tutors from universities. Okay, they some radiographers, the departments to manage the clinical education. But the times these tutors are just to manage. They will not be the only ones to teach. So all radiographers in the department are supposed to be teaching. Okay, and then the radiographers, they don't stop seeing patients when they are appointed clinical tutors, or when students come for clinical attachments, we don't choose radiographers to say you will just be teaching and you will not work. No, all radiographers will teach and they will also do clinical work, because we do not have positions yet in Zambia for clinical educators or clinical supervisors like other cadres, like nursing or clinical officers. So our radiographers carry dual roles. Okay. And again, the current situation in Zambia, we have no training program to support radiographers who teach in clinical education. So we teach the way we were taught. So if I was taught not to greet patients as they come, I will teach the student in a similar manner. So we have no uniform or no program to teach the radiographers how to teach in the clinical area. So we teach the way we feel. So there's an even clinical learning environment due to different teaching approaches and skills by clinical educators, because we teach the way we were taught, okay? And therefore, the problem that we have identified in the current clinical education practice is lack of planning, okay? We don't plan the way we teach. So if even Horn College or University of Zambia sends their students for attachment, what we have observed is that students will come, they'll be welcomed, but the way we teach them, we have no system to follow the objectives of that particular clinical attachment, okay? And then 2, we do not supervise students in an appropriate way because of lack of planning. And also the feedback is neither there nor here. Sometimes the student will make a mistake, a radiographer will just keep quiet, for example, or they will shout at the student. There's no formal way of providing a feedback in a positive manner to make a student feel that what they did was wrong because of A, B, C, D, or what they did was right, so that they can be motivated to do even more of such kind of good things. So we have no system in place, in short, or if it's there in hospitals, it is not like similar across the board, okay? And then we have seen that our radiographers who teach in the clinical area, they fail to appreciate the education principles. Remember, students learn differently. Just like in theory, the education principles, okay, learning theories, we've been taught that students learn different. People learn different, not even students. People learn different. There are slow learners. There are students who learn by just looking. There are students who want to touch and look. There are students who want to hear. So in a clinical education practice or program, it's supposed to have a system where when the students comes, they are reminded of their theory, which is when you are teaching and they are listening, then you allow them to go and touch, you bring them back for a feedback. So you are interacting through so many ways of learning, and the students who don't understand when they're being taught, when they touch, they will understand. Those who do not understand by touching alone, they will understand when you are talking. So we have to have a system where all students, all types of students are catered for, and they are not, no one is left behind. Okay. Again, we also have a strong will, because regulatory bodies and the professional bodies like the Radiological Society of Zambia, they are there to ensure that where our students are sent, okay, the clinical settings, they are actually inspected to ensure that they are ideal for our students. Okay, so the clinical environment is approved by professional bodies to ensure that there's a physical space, there's availability of training resources, there's quality of educators of quality, and there's safety of our patients and the learners. This system is available, but now if it is implemented to 100% is where we need to find out, because we have seen that where our students go, the physical space may be there, but our educators, our clinical educators, the geographers who teach there are not trained. Okay, so already there is a gap. The professional body has said this place is safe for our students to go there, but there are these things that are within us that we need to start strengthening. Okay, the space is there, machines may be there, although we also have a hiccup there. Sometimes machines are working, sometimes not, but in principle, when a space is inspected for our students to be going there, they are saying the machines are there. The people who teach are there. But those people who teach are not taught how to teach. So this is where the gap is. Okay, the safety of the patient will be there and the learners will be safe. But those people who teach are not trained on how to teach the students in the clinical area. So this is where the gap is. Okay. So I have said that we have a system in Zambia where we have schools of radiography who teach theory, and they also prepare our students before they come to us in the clinical area through simulations. And when they come to us, we have space for them, they come to learn, okay? Although we have also these gaps where our learners, our trainers are actually not trained to teach in the clinical area. And we also have these regulatory bodies who ensure that our students are safe in where they are, okay? But I still have these questions to the audience. From what we have currently and what I've shared, the status of what we have now, can we say we have a clinical system in Zambia? I'm not saying you answer now. Can we say we have a clinical system in clinical education system in Zambia? If it's there, is it effective? Okay. Or what are the challenges of clinical education system? If we have challenges, what are we doing to make our system effective? Okay, these are just for us to digest. Okay. For me, I would say the clinical education system exists because if you look at this clinical learning cycle, we prepare our students very well, theoretically, okay? And also our students are exposed to simulations through laboratories where we are not very sure is how much they are prepared before they come to the actual clinical practice setup. Because when a student comes, for those who have been in the clinical area teaching, when students are sent to our hospitals, okay? First of all, they exhibit themselves as if they have never heard of even theory, okay? They look so lost. They look so blank, like they've never sat in class. They have the theory, but they are a bit scared to expose themselves that they know something, okay? What is the problem? The problem could have been maybe they didn't have enough preparation in the laboratories, in the simulations, because of so many reasons. Our numbers of radiographers these days per class is so huge. So you find that even these simulation laboratories are not enough for our numbers. So there are some students who are, as I said, learning in students is different. Some students are very fast, so they'll pick something quicker even in the laboratory. When they come to the clinical area, you can see actually that these students have got something they learned in theory. But others are a bit slow learners. So if there is not enough time or enough space for them to be exposed in the clinical laboratory due to their numbers, the class numbers are so huge. So we find that other students actually lag behind, okay? So, and again, do the lecturers here on theory and the lecturers, the clinical educators in the practice have enough time to discuss these students? Okay, this briefing here, do we have enough time to discuss the students before they come here? Because when they come here, we are expecting clinical educators here in the clinical practice to know each student, okay? Who are the slow learners? You should have gotten that information from the theory lecturers, academic lecturers, in short. So the handover between the theory educators and the clinical educators must be strengthened so that when they come here, the clinical educators are already aware which student here needs more help, which students here needs this and that, okay? More time in learning one particular site, for example. So this information is very, very important for us to ensure that our students here in the practical area are well prepared and well received. After that, of course, we need to see how these students have learned through assessments. So we do assessments. So the cycle is followed, but how effective, for me, I would say is not very effective because of so many reasons. Why it's not effective? I'm saying it's not effective because our clinical educators have no skill. They know how to teach on their own, but they do not have a skill to teach in the clinical area. They are not taught how to do that. So those who are interested, they just do it the way they want to do it. So we have a gap which we need to bridge. And of course, we have so many challenges. Okay, so that's my answer to the questions. I don't know what others would say. Okay, so if I'm going to summarize challenges, the first challenge that we have noted in the current clinical education system in Zambia is that we lack strategies to support radiographers in the clinical teaching and how to assess our students. We have no training, not even CPDs, to ensure that our educators in the clinical area are strengthened in terms of skill to teach students in the clinical area, okay? And again, sometimes we lack sustainability in consumables and equipment. So you find that students are sent to a particular practical site and they stay there for a month or two without doing anything because the equipment is down or there are no consumables, for example. Okay, so this is another challenge that we have that is not on our side in terms of effectively training our students. And sometimes just the staff themselves, the clinical educators in certain placement sites, they are so unfriendly. So the students are not given that environment for them to express themselves, to ask questions. And sometimes we treat these students as if they came to work, okay? We give them a lot of things to do to clear the lines. And in doing that, they have no time to discuss or to get feedback from you. Okay, so the system is not just there to say, okay, these are students, and then maybe each student should have 5 patients, and then you give them feedback, you allow them to ask. We have no, in certain sites, students have complained that the staff is very unfriendly, so they don't give them time to interact. Okay, and also lack of incentives to our clinical educators, because most of the educators are teaching free of charge, they are not paid. Okay, so because of that, they would rather clear their line, okay, the line of patients, and then go and do other things. So lack of incentives to clinical educators is another challenge that we had for a long time in Zambia. Even those who are appointed as tutors, I don't think their remuneration is as attractive. Okay, we have no positions in government for clinical tutors like other cadres have, and this is another area where we need to fight to ensure that we have clinical educators in radiography who are paid as clinical educators and they are trained as such. Another challenge that we have seen is that the curriculum design and the implementation has challenges. Not that the curriculum is bad, no. In the way we implement it in terms of clinical education, because the curriculum has very clear objectives of what we want our students to become when they finish. But when they are in the clinical area, okay, the clinical educators, some of them are not given a chance to look at this curriculum. They actually don't know what the curriculum is talking about, okay? They will come and they will teach the students whatever comes their way. If I'm in a chest x-ray room and my students are attached to my chest x-ray room, even if that week their objective is to learn a hand, okay, want to do a hand or a foot, I'll teach them what they found me doing. So this is where, so by the time they are finishing their 3 months, probably they have 50% of the objective will not have been met. So there's this thing that we need to align. Okay, the clinical educators, when they are trained, then they are aware that they need to know what the curriculum is talking about in terms of the outcome of our learners at the end of the training. Okay. And so, as earlier I mentioned, we have limited career development and progression opportunities to support clinical education. Okay. Insufficient skills, lab training prior to clinical placements. Sometimes we lack, our labs are not well stocked because of the expense, and what we have cannot cater for all the students at the same time because our classes are very large. Okay. Sometimes we have very good clinical sites. Like in Zambia, we have a hospital called Chinsali in Northern Province, which is very well equipped. But because of distance, all our universities are in Osaka. So it's very difficult to transport these students to go to such clinical sites. Okay? A large group of students have already talked about it. And sometimes it's just the students' attitudes themselves. You want to teach, but they're not ready to learn. Okay, so how do you handle such students with that attitude? This can only be done with a very experienced educator who has been trained to teach in the clinical area. They will know how to handle students with the attitudes in the clinical area. Okay. I'm almost there. All that said, how then can we change to improve the way we do things in training our students in the clinical area? What would we do? What are our changing perceptions towards clinical education in radiography? Okay. Unless we understand the focus of clinical education, we will not put a priority to ensure that we improve it. When we know the purpose of clinical education, then we will know we'll know what to attach, how much effort should we attach to ensure that it's improved, okay? So there is need to realize that if we don't plan well, and if we don't teach our clinical educators to supervise and provide feedback during clinical teaching, we will always miss it. Okay, so we need to start planning, to start training, to start ensuring that we have an official clinical education program with all it needs to ensure that it's effective. So that our students, when they are attached even for 3 months, by the time they go out of the clinical area, it can be somebody who can do at least something with a very minimal supervision. Okay, because remember, after the attachment, they are going to work, they are going into the industry. And this is why, if you've observed in Zambia, when students graduate, as they are waiting to be posted, they volunteer, they come. Those students who volunteer, those who work in the clinical area, you'll see how they struggle. You'd think they do not pass through our hands. They can't position a hand, they can't do this. The attitude is already bad. Where is the problem? The problem is from us. So we need to ensure that we put more effort to ensure that the clinical education is strengthened. The theoretical part of it, I think for now, we are fine. Okay, so we need also to understand the importance of providing a suitable clinical learning environment for our students. A suitable clinical environment does not only mean good equipment. We are talking about us radiographers with good attitudes, us radiographers to be role models, to teach through what we do. Okay. Again, we need to have we need to recognize the need and the support that we need to the clinical teaching players who are a student, a teacher, and a patient. Okay. How can we ensure that a student participates in the clinical learning? It's by providing a conducive environment for them and make them feel part of the team. Because when they come on attachment, they become our community members, okay? They're part of the radiography community. So we need to provide this environment for them to be free, to ask, okay? To interact, to try things. This is why students are sent to a teaching hospital. Let them try things so that steadily we can move them from novice stage until when they are expert students in what they do. Okay. So this is just a framework that I thought I would skill to a student. Okay, they will learn, they're observing. Definitely when they come, we don't allow them to just touch like that. They will observe. So as they are observing, you are interacting with them, you are asking them questions, then you allow them to practice, you allow them to prove that they can actually demonstrate a skill. Okay, they perform. And how do you maintain to ensure that they do not forget? Is by doing more and more. And when they get back to their university, they continue with the simulations. So we have this situation where we deliberately need to come up with an environment where a student is free to demonstrate, to prove themselves that they can actually do, as you are around to ensure that you supervise and guide them and give them feedback where they go wrong. And when they do right, you give them a feedback. Okay. Clinical supervisors, this one we cannot even hesitate to say that we need all our clinical educators to be trained, to have a skill in clinical teaching. They have the will, they have the zeal, they like teaching. This is why they've continued to teach without training. But is how they teach, how it's supposed to be taught, how they're supposed to teach? The answer is no, because teaching has it's a skill on its own. Okay. Globally now, there's a recognition worldwide that we as clinical educators are very good at what we do. Our teaching is further enhanced by undertaking a clinical education course. So we can't run away from it. Just like the way we take a course to teach theory, we need to take a course in teaching clinical education. Okay. Unfortunately, if we teach without a skill, this is how come we are seeing poor practice in clinical education, because we are just doing the way we do it. We don't know whether it's right or not. Okay. So we need to ensure that our radiographers have got an expertise in teaching the procedure and how to assess. Very important, how to assess in clinical area. Okay, provide a conducive learning environment, we said, and they should recognize that their position is a teaching model as well. Okay, just you being a radiographer in that department, as you work, you are a teaching model. Just like I'm using a computer as a teaching model, we are a teaching model. The way we work, the way we talk, the way we treat patients, the way we treat ourselves and our friends, we are a teaching model. Okay, in terms of a patient, they're also very key. So we also need to understand and respect these patients. Okay, they are a key element in clinical teaching, and it's very important to ensure that we obtain consent. But what we are doing now, every patient who comes, we don't even ask them whether our students can learn on them or not. And this is why we can't even probe more questions from students, because we are fast. We just want to do the patient and go. And this patient just sees everyone as the staff. They don't even know there's a student who wants to learn. But if we ask a patient that, oh, we have a number of students here who wants to learn on your case, they'll be very willing to even explain and express and give you more detail, okay, of what you want to know about their disease and how you can do it. So patients come with different diseases. So a range of patients seen by students in a clinical attachment should reflect the expected learning outcomes, okay? So if your learning outcome is to ensure that students learn CT, of brain CT, MRI, whatever. So ensure that all the patients who come, you already select that my students today, they are learning on this. Okay, so the learning outcomes should determine which kind of students, patients are you going to allow your student to see. It's not every student, otherwise you're going to confuse your students. If next time they see, 1 minute they see chest, next time they see, in the next minute they see CT, the next minute they're in ultrasound, they'll be confused. So let's look at the expected learning outcomes of that day, or that month, or that 3 months, and choose patients according to the learning outcomes. So patients can be selected according to the problem that they're presenting, if they are available, or if they are willing to cooperate with the students. Okay. Yeah. So even with all those challenges, there's something that we have been doing in Zambia, okay, currently, to improve on clinical education. Research has been conducted. Dr. Wanga and his colleagues very, very keen in improving clinical education in our country. Therefore, they've done quite a number of research just to look at the clinical education status, the challenges, and how we can improve. Okay, so they did a research whose purpose was to share findings and recommendations on how they can improve clinical education in Zambia. Okay, so like we have this paper where they did to develop a framework. This was done by Dr. Bwanga, to develop a framework strategy for supporting radiographers, okay, in clinical supervision of radiography students in Zambia. So he came up with so many strategies that he proposed to us to implement, okay? And he said, we need to have an education and training program to teach clinical educators, okay? We need to ensure that resources are there to ensure that the clinical education is not interrupted. We propose also for human resource and relationships to appoint designated clinical supervisors at each hospital in the government, on government payroll. So he proposed that radiographers should be employed just to teach, so that they have enough time, okay? They are trained and they are employed as clinical educators. And also he proposed another strategy to implement a quality assurance or clinical quality assurance or teaching audits in these universities, to ensure that everything that we do is in line with clinical education things in Zambia. So he proposed all this. So we can pick one by one to implement. First of all, we need to have a training to educate our clinical educators. When we have trained clinical educators, then we can lobby for positions. Otherwise, we cannot go for lobbying positions and when we have not trained clinical educators. So which one is the first? We are saying, let's look at how can we have our clinical educators trained to have a skill and a paper that we can justify to say, we have this cadre and we want positions. Another paper was also done again by Wanga and Dr. Sichone. They were looking at the experiences of our clinical supervisors, okay, in clinical training of radiographers. And through this paper, a lot of things came out. I'm sure some of our colleagues in this meeting participated in this research. And the experiences were actually, all of them were saying they need training because currently what they are doing is not according to what they're supposed to do. Okay. Another one again, Wangandi and Kaonga, the factors affecting us in clinical education, it brought out a lot of issues that we can follow up. Okay. So in a nutshell, we are doing something. We are not just watching the challenges, we are doing something. Research is being done. So we have evidence that we need clinical education improvement because radiographers have expressed themselves that they actually need to be trained for them to implement this training well. Okay. So what are our recommendations? We need to have to support our clinical educators by acquiring a skill. Okay. And a general health professions preceptors training manual to this line has been drafted under the Reverend Manawasa University for health professions education. But this one is not for radiographers alone. It's a bit diluted because it cutters across. So if we want a specific radiography training, clinical training, we need to come up with our own clinical training program and implement it. Another recommendation that we need to provide a conducive learning environment. Okay, we need to create positions for radiographers and develop a clinical education training program for radiographers. Encourage our learners to be responsible, to take up their learning seriously. Okay, and also to strengthen the collaboration between training institutions and clinical learning facilities. Be reflective on the clinical teaching system and methods. This is what we are already doing. We are now reflecting on what we are doing in the clinical teaching, and we are coming up with strategies of how we can improve it. Okay. What can we learn from other cadres who have been in doing clinical education in Zambia? In Zambia, I can pick of nurses. Okay, nurses, they have a clinical training, clinical education program, which they do, I think, at diploma level. And they have positions for these nurses employed just to teach nurses in the clinical area. So we can also learn from this. If they did it, it means it's doable to all of us, be it in Zambia or other countries. Okay, nurses are almost ahead of every cadre in the health professions in terms of how they do their training. Okay. So the clinical education courses to support clinical nurses is available in Zambia, and we can learn from this. If we go to Europe, we have universities that are offering clinical education at master's, diploma, certificate levels, just in clinical education, not health professions education, clinical education. Okay. So they conduct also audits to ensure that this clinical education in hospitals is done according to how they're supposed to be done. So when they're doing audits, they ensure that the clinical educators are trained and they are certified. You are even registered as a clinical educator. So we then are safe to say, oh, students are in safe hands because they are trained by a trained clinical educator. Okay, I think having said that, I'll conclude on this slide of saying we can also learn from others who have already gone ahead of us to train or to have programs in clinical education. So even as radiographers, it's possible. We can do a clinical training education program where our radiographers are trained and lobby for positions so that these clinical educators are motivated to teach our students. Like that, then we will see an improvement in our graduates. We will see competent graduates coming out because they are being trained by competent clinical educators. I thank you all. Thank you, and I hand over to the chair.
Thank you so much, Madam Nchebe. Indeed, this was a wonderful presentation, and I'm glad that we are wrapping up this year with a presentation on clinical education. So indeed, clinical education is a hallmark in producing a competent radiographer. And who are the vanguards? The vanguards is us, the radiographer, to ensure that this clinical education is implemented effectively. So thank you once more for this presentation. I think at this time we can have questions and contributions, maybe from 3 or 4. Then from there, I will make some few announcements. Then after the announcements, I can see Dr. Wanga is on the call. We'll allow Dr. Wanga to say something. Then the meeting will be closed by our president. So thank you so much. Mr. Mwenda Christopher, you can kindly unmute yourself and make your contribution, or you can ask your question.